Hello,
Okay,
everyone.
Maria, the floor is yours.
Hi, everyone. Good evening, and welcome to our monthly Shine webinar by Morocco Sim. I'm Dr. Miriam Arami. I'm a surgery resident in Germany, and I'm also the General Secretary of the Moroccan Society of Simulation Healthcare. Today, I'm very, very happy to be welcoming a distinguished speaker. We have today with us Professor Jared Katzen. He's currently the president of SSH, which is the Society for Simulation Healthcare. He's also the head of the STAR Simulation Center in New York, Monsignor. We also had the chance to meet him at IMSH, which is their annual congress, and also to visit his amazing simulation center. Today we will gonna speak about in situ simulation. Dr. Jared is gonna share with us his wealth of expertise, his perspective and his work and leadership in highlighting the evolving role of simulation in situ. We will start with 30 minutes, a 30 minutes presentation, followed by a chance for open discussion and a chance for questions and share reflections. Dr. Jared, the floor is yours. You can also, for people joining us, you can also write your questions on the chat, or maybe at the end, just raise your hand and ask directly.
Absolutely. Seeing as there's, a small number of people here, we're happy to have you come off of mute and ask your questions at any time. Um, the way my screen's arranged, I'm not sure I'm gonna be able to see the chat, so just feel free to interrupt me, Mohammed or Miriam, and if there's a question or anything, we're happy to pause. Everyone can see my screen? Yes?
Yes, it's okay.
Yes, perfectly.
Perfect. So it's an honor to be with all of you today. The opportunity to talk about simulation, to share a little bit about how I do and what we do in terms of simulation, especially for patient safety and process improvement, outside of the four walls of our simulation center is something that I'm really excited about. We do a lot of these in situ simulation programs. And so it's taking that educational lens off of the simulation program a little bit and putting more on the process improvement, the patient safety, the quality of healthcare hat. And I'm going to spend a couple of minutes talking about that today. You already got a wonderful introduction. You don't need to hear more about me. I like to just let everyone know, again, president of the Society for Simulation Healthcare. I am authored a book with Springer, so we do get royalties, or I get royalties from that. And then I always like to let people know that I'm a big soccer supporter, so much so that I own a very small share in my local soccer club here in New York. But Mount Sinai is located in New York City. We are a six-hospital system. We have everything from community hospitals to academic medical centers. And I'm going to talk a little bit about what we do here in terms of in situ simulation, and then share some resources, and maybe pose a couple of questions that I'm interested in getting your thoughts on in terms of what in situ simulation is and how to do it. So, with that, and I think I actually might be able to see the chat, so this will work perfectly as long as I can move this out of the way. So the goals here today are to discuss in situ interprofessional IPE simulations for patient safety and to improve patient outcomes, and review some of the resources that are available. So just to begin, a definition of in situ simulation. This comes from the Society for Simulation and Healthcare's dictionary, which is publicly and freely available on our website. I want to call out a couple of key components here. Number one, it's about being done in its own environment. It's about the actual patient care setting. So where patients are being seen is where the simulation is going to be happening, not in a simulation center. It should be team-based. It should be announced or unannounced. And this is where we get to have a little bit of a discussion as to what you think of the best of doing it. So I'm curious, you can type into the chat, you can raise your hand, you can virtually raise your hand. How many of you currently do in situ simulations? Just out of curiosity. So I see one. It's hard to see everybody. You can just type a yes, a me. Great. Okay. And so the question is I have is where do you do them? Do you do in the hospital environment, in the inpatient or emergency department setting? Do you do it in the outpatient setting, in the clinic environment? Do you do it in the boardroom where for your hospital administrators or in the lobby or in the parking garages? And how about at major sporting events? And so I see pediatric emergency in a hospital, very common. And one of the first in situ simulations that I ever was involved with was actually in the boardroom, not even in the hospital setting. But I see lots of EDs, hospitals, emergency department. So my background, I'm an emergency nurse by background. I'm a faculty member, professor of emergency medicine and medical education at the Icahn School of Medicine. And then my other passion is in the EMS, emergency medicine, emergency medical services, so ambulance services, first responders. And so one of the first in situ simulations I ever did was revolving around CPR and the use of automated external defibrillators. And we wanted to make sure that we had defibrillators publicly available within the hospital setting for the lobby, for the cafeteria, where all these different environments. And we got a lot of pushback. And so we brought our mannequin to the boardroom and we laid it there and we called a code. And the reason that we did that was because the hospital administrator said, we don't need to have defibrillators. We have a code team who responds. And so we did the in situ simulation in the boardroom during a board meeting. And we sat there with our watches and we timed how long it took for the code team to respond to the boardroom. And it wasn't a minute, and it wasn't 2 minutes, and it wasn't 3 or 4. It was 7 minutes for the hospital team to come. That's a 70% less chance of survival. And the people standing in the room all looked at each other and they didn't see they didn't provide care for the patient who was lying there. After we did that, we got the money approved to go out and purchase the defibrillators and do the training for it. And so we want to start thinking about how we use simulation a little bit differently, not just for what we do all day, every day, but to further our agenda, to get people to see what the next steps are in advancing our safety and quality initiatives. So why do we do in situ simulations? Well, there's a whole reason behind it, and I mentioned some of them, but it's this idea, and this comes from the SSH accreditation standards. This is about making sure that you have documentation about the performance improvement activities. How do we make sure that we're actually meeting what our mission is, which is to drive improvements in patient care, improvements in the safety, and make sure that what we're doing actually meets the patient? So much of what we do is in the educational setting, in a sim center, focused on improving the knowledge or the skills. How do we demonstrate that that knowledge or skill acquisition actually impacts the patient? And this, the in situ, the process improvement programs are our opportunity to do that. So here's an example of an in situ simulation we did a couple of months ago. This is at our urgent care setting. Now, our urgent care setting was opened up in a ancillary building because of one of our hospitals was shut down, the emergency department was closed, and in our agreement with the state of New York, we had to open up an urgent care setting not too far away. And so we went down there with our mannequin right before they opened, and we did some drills. And I'm hopeful that you'll be able to hear this. But this is one of our nurses, and this is the nurse manager. Now you can't really tell, but in this picture, she's on her phone. She's making a phone call, and I'll let you watch just a little bit. And hopefully you'll be able to hear. If you can hear, just let me know.
With the override, she put in a temporary patient, and then she put in 5 letters of the bed, and it's not coming out.
So she's on the phone. She's making this phone call to pharmacy or to IT because we ran a scenario of an anaphylactic case. And this nurse went to the medication dispensing machine and typed in anaphylaxis so that they can get the epinephrine, the adrenaline, and all the medications. And her screen was blank. There was nothing there. So she typed in EPI, nothing came up. She tried the generic term, adrenaline, ADR, Nothing came up. This nurse did not have access to the medications for this emergency. And so real time, we're trying to troubleshoot this. So they said to me, we actually have a system in place for this. And so what we did was we looked at their systems and we developed this after action report. And we did this in our format where we talk about the situation in blue, the S, the B for background, the A for our assessment, and then R in red for our recommendations. And we had 10 different recommendations based upon what we found. So some of them were to make sure that staff has access to the medications that they need. But this was their workaround. They took the medications that they thought they were going to need and put them in a cabinet, unlocked. And so we started looking at this, and I started digging in, and I started taking some pictures. And so these were some of the medications that were just laying out, and these were some of the medications that were in these little gray containers, just white pills. A little concerning. I'll tell you that one is acetaminophen and one is ibuprofen. Again, the end of the world? No. No one's going to get hurt because they got Tylenol or ibuprofen, theoretically. But we'd like to make sure they get the right medication. So there's our ibuprofen, there's our acetaminophen. But this was where it got more concerning because we had these vials. And I took a picture of the top of those vials. And you can see they're both purple in color, maybe lighter and darker. Easily confused. And so what those actually medications were adrenaline and xylocaine. That will cause a problem. If you inject xylocaine via IV for a patient who's having an anaphylactic reaction, that could be an issue. So we said this is a problem. We have to fix this. And then we started to uncover more. We opened up the code carts that they had. They had two different code carts in that environment. And it's going to be hard to see it, but I'm going to see if I can pull up the pointer here. You see, this is that purple top medication that we were just looking at. Or so we thought. This, and I don't have it zoomed in anymore, is actually ephedrine. This glass ampule is the epinephrine in the code cart. Over here, the green vial is ephedrine, and the glass ampules over here are the medication that we need, adrenaline. So now we have two purple top medications that are not being stored appropriately. Now we have different manufacturers in the same environment, and we have ephedrine in purple, we have epinephrine or adrenaline in purple, we have xylocaine in purple. In an emergency, somebody's going to mess this up. And so we only found this because we were looking for these opportunities to improve patient safety, to improve our processes. And so here's another example of an in situ simulation. Now, this isn't a true in situ simulation. This is more process improvement. This is in a office setting, classroom setting, where we were walking through the process of opening up a new emergency department. See, our emergency department at my hospital was built in the 1970s to accommodate about 70,000 patients. We're seeing about 120,000, so about half the size. And so we're going through all of these new processes. And what I love over here is you'll see this is actually one of our vice presidents, and this is one of our materials service people. And in his hand is a water bottle, but he's using it as a metal detector, a wand, because he was playing the role of security. And this gentleman sitting in this corner over here, this is actually our system chairperson, who is now the CEO of our entire health system. And we were walking through the processes, and you can see we laid out arrows on the floor of triage in the emergency department and where patients are going to go and how they're going to be split off and what this is all going to look like. And so we worked as part of this redesign team. And so we were embedded in the redesign team of the emergency department to ensure that the ideas that they had actually came to fruition and actually worked appropriately. And so this is our emergency room. This is sort of the processes and the area that we were looking at. And we were looking at patients walking in through the front door, coming into this area. And what we knew is that if we keep patients sitting up in the emergency department, they take up less space. Not only do they take up less space, but we can move them through faster. So we wanted to see how that process would work. And so we actually used our patient family liaisons. We had our process improvement people. These are not real patients. These are all actors that we were utilizing, and we had security. We had everybody involved. And here's an example of the process that we found. Now, you see, what we thought was that we could have virtual physicians, assistant physicians, other people to do some of the intake process. So we wanted to see what that would look like. So we tested it. So this is one of our emergency medicine doctors. She's standing there. She's interviewing a patient who would be sitting out in one of our triage bays. And we were okay with all the noise. And there's our patient sitting there. And here's another example.
Get things started for you, but I just want to hear a story and see if we can kind of get a few things started for you so we can minimize your wait time.
And what we realized
Yeah, I was just on a walk
was
with a
that
friend and I tripped.
when you're sitting there talking to somebody on a screen, there was no privacy. Everybody could hear the whole conversation. Not only that, when you're talking, you can't hear, you make the volume louder. And therefore, even more people can hear. And so, this whole process of virtual triage and starting we said it's not going to work. And so, we went back to an in-person process, which had more flexibility, more opportunities for interactions. But we would have never known that these processes didn't work unless we tested them. Here we are in the new environment, opportunities to do scenarios focused on pediatrics, but giving our learners the opportunity to actually touch and feel the machines and the equipment. And that's another important part of this. I don't have all of the equipment in my sim center. So this is an opportunity to make sure that they know how to set up this piece of equipment, the baby warmer, the giraffe, so that we know how to warm the child and give them oxygen and suction and stimulate them and all of the things that we need to do. But we might only have one or two pieces of the equipment like this in our institution. And so doing this in the actual environment so they know how to set it up and where it's kept and how to move it is really, really important. Again, we were moving spaces. This is a pediatric patient, but this isn't really the pediatric emergency department. This was a temporary home for the pediatric emergency department for about 9 months. So we had to figure out where they were keeping the equipment, where they were storing their Braslo tapes, their color-coded tapes, their measurement tapes. They were supposed to be hanging on the wall. We walked in one morning and they were not hanging on the wall. They had to go and find it. And then a patient came in and they used it on the patient. But because we tested the system, we actually were able to demonstrate that patients got better care because of the work that we did. So some team training and some uncommon occurrences. Again, this is one of our smaller community hospitals that doesn't do a lot of pediatrics, doing pediatrics with them, practicing different techniques, intraosseous, as you can see here, measuring, bag valve mask ventilation, intubation, all of these things go into ensuring that we have a ready and prepared workforce. This is, again, one of our community hospitals. These are all nurses and advanced practice providers, nurse practitioners, physician assistants, where we're doing trainings in their actual clinical environment, and we're able to look at different things. For example, what equipment do you have stored over here, right? Is there enough room in the environment? What equipment is in these cases, and do you know how to open them? So then I share with you a short demonstration of, is this in situ? I had the opportunity to go out to an area of New York known as Randall's Island, and there are soccer fields and ball fields, and the fire department of New York has their training academy there. And so I show you this picture, and this is a subway, but this actually isn't a real subway. It's part of their training environment. And in this environment, you can put smoke, you can put sounds, you can crawl under the train. The train can move a little bit down the environment. And so people can practice working in these austere and challenging conditions. And so you can see we put a mannequin underneath the train, we put our mannequins underneath the cars, we put our mannequins wedged in between with bleeding. And we did this with the use of our simulated vehicle here. And so we brought this vehicle out to the training environment so that the fire department could actually working in that environment in terms of managing the patient. They also have a flight simulator. They're still getting this up and running, but how do you deal with medical emergencies on airplanes, for example? This is another example. So you saw the fire department a couple of minutes ago. That's a real in situ, well, sort of in situ. right? We didn't put them on the real train tracks. We didn't put them in the real subway station, but they were able to create such a realistic environment for training that it's probably a pretty good substitute. Probably better, more realistic than any simulation center that you or I have in our hospital environments because it's not perfect, right? We don't have maybe real oxygen or the real IV pumps or, all of these other things. We don't pump smoke in or shut the lights off all the time. Their training environment allowed for that. But here's another example. So this is our mannequin in the front seat of a colleagues of mine car. We drove an hour outside of New York to a small community, and we put the mannequins underneath the car.
I'm seeing the fire department. Yeah, the highway's backed up. They're gonna get at it.
And we didn't just run one station underneath the car.
I was provided where your favorite highway tax car is. My fucking look at me off of this car! Is it flip coming?
Here's our second station underneath the car. And our patient had to be removed. But this was in the back of or in an ambulance building or a fire department. And they brought their vehicles, their actual vehicles, and we put the mannequins underneath. So, is this in situ? I don't know. We're not on the side of a road. We're not in the middle of the street, but we're using a real car and they're real ambulances. It's pretty in situ. Now, they brought the patient, got him out from underneath the car, brought him into the back of their ambulance. Here they are.
Running epinephrine.
The site, the sound, they're real equipment, they're real vehicles.
Okay, we'll give him bicarb since he just went under.
Okay.
Bicarb on board.
Okay.
Check a sugar level with the sugar.
Okay. Sugar is 120.
All right, sugar.
And so this was pretty realistic. It was nighttime, it was out in the environments. And then this is my colleague Duncan, and Duncan and I decided we really wanted to make it even more realistic because ambulances aren't static. They don't just sit there, they move down the road. So this is not Duncan just getting exercise, but making it feel more realistic.
You don't hear anything anywhere.
As he bounces on the back of the ambulance.
A lot of resistance.
The whole
ambulance is bumping down the road.
And so we wanted to, again, add that element of realism to this.
You don't hear anything.
And what we were able to do is bring a bunch of our physicians and nurses from the hospital up to this fire department and do these trainings in their ambulance bays, in their fire department bays, and give them a realistic learning experience. And so we do bring this training out to our teams. We have signs that we put up in the hospital when we do these drills. These are an interprofessional group. We have nurses in green. We have physicians, consultants. We have fellows and faculty members. This is pediatrics, and we have nurses and techs and physicians, bringing it out to them, to their environments, and giving them the opportunity to practice. I'm going to wrap up in just a couple of minutes, but here's another example of an in situ simulation. We're very fortunate that we get to go to the US Open. Wimbledon is taking place right now, the first rounds. This is the US Open that takes place in August and September of every year. And I have two rather short videos that will show you what we do at the US Open.
We just brought our new Simulation Teaching and Research Center, or STAR Center, ambulance here to conduct a on-site emergency drill as part of the player down scenarios. We've done this for a number of years now, and this is an extension of the programs that we run in the hospital and for the health system. Our new ambulance allows us to bring our programs, which uses high technology, mannequins, and virtual reality equipment, out to the community.
So we do simulations monthly in our Pediatric Emergency Medicine Fellowship. Sometimes we do it in the STAR Center, so it's really just the fellows. We practice teamwork, we practice procedures that we don't get to do down in the ED very often, because the communication during these simulations are so important. And then once we do have a case, we can really, act on those skills.
I think getting all of the kinks out versus communication, all the logistics between the patients, the family members, the nurses, the medical staff, working together closely. If there's some kind of emergency happening, all of those teams really need to work together and with like a well-oiled machine. And so simulation practices all of those things ahead of time in a low stress environment, so that way when something actual is happening, everything can work together well.
So our new training vehicle, we'll be bringing it to community health events, street fairs, and throughout.
So we just brought the PR that we get out of this is also invaluable. right? So we get to demonstrate how we're making a difference to the community, to the city, to the larger area, not just our hospital setting. This is a similar video, but this shows you more of actually the drill that we conducted on site.
Mount Sinai and the U.S. Open have had a long-standing relationship, and one of the benefits of this relationship is that as Mount Sinai continues to innovate, we can also be innovative in the ways we do our medical preparation for the U.S. Open.
We ran a player down simulation.
Does anyone know CPR?
Hey, I just got here.
Hey, can you perform CPR?
That is intended to practice a rare event when an athlete would go down on the court and be unresponsive. We were specifically practicing for cardiac arrest, but this also includes players who might go down for heat stroke or a seizure or, rare case of anaphylaxis. But if we don't practice it, you won't be as prepared as if you practice it many times.
I'm feeling very dizzy.
So you can actually talk to him and get a response. And that's what we want to see, the first person who's here to actually assess the patient.
One of the most innovative parts of the medical school is a simulation lab. And this year we've been able to bring the simulation mannequin on site at the US Open and actually practice on a mannequin that can give us responses and simulate cardiac arrest, which has really been a very educational experience for our team.
We know the medical side, but you're bringing a ton of people together who don't normally work together. So it's incredibly helpful to get all these people together who don't normally work together to then practice for this rare instance. That way, should it happen, we are prepared. Everyone responding, CPR is in progress, confirmed cardiac arrest. We need all hands on deck, all hands on deck.
Don't touch patient.
Stay clear. We know that our response time is incredibly important. If a player, God forbid, had a cardiac arrest, having the response time for an AED, for example, an automatic external defibrillator, is incredibly important because every 10 seconds of delay increases morbidity and mortality.
So you get the idea that what we're doing in situ, in the actual environment, has the opportunity to make a difference and save lives, improve the processes, and lead us to better, higher quality, safer care, better teamwork, better team dynamics. And there's a bunch of resources. So this is one of the resources. It comes from a group up in Canada, a pre and post in situ simulation checklist here, going through the staffing needs, the clinical load, the workflow. And so you can grab this resource through the QR code or going online and finding it. We take our ability to make sure that we do the simulation safely very seriously as well. So we make sure that all of our equipment is labeled not for human use. We don't want to accidentally introduce some of our equipment into the actual supply chain for the hospital. So all of our equipment is labeled with these labels. You can, again, get the QR code, you can go online, you can purchase these labels through the Society for Simulation and Healthcare so that if you're doing in situ simulations, you're doing them safely. And then lastly is this article by a couple of colleagues of mine, Komal Bajaj and Katie Walker and Mary Patterson and Michael Megarduchian. And they were talking about some of the no-go considerations for in situ simulation. And they list them. They list them as staffing and workflow and clinical load and equipment needs and unanticipated events. And they say, maybe you shouldn't do these in situ simulations if a cardiac arrest just came in. Maybe you shouldn't do it if your staffing needs aren't where they're supposed to be. And I take a little bit of a different view on that. I think that what better time to do it than when you have another event unfolding? If you can't manage 2 cardiac arrests simultaneously, well, then you have to figure out how you're going to do that going forward, right? If your staffing isn't where it's supposed to be, what happens when the bus accident happens later that day? What are you going to do? So I think there are some opportunities when you may not want to do the in situ simulation. If the bus accident just happened, if a mass casualty event, a bombing, a shooting, a train derailment just happened, then maybe we don't want to do it. But if it's your normal, everyday sort of routine care, and you operate at a level that isn't sufficient to allow for an additional emergency to happen or additional things to occur, I think that's a part of the debriefing and the conversation that you need to have. I think the most disappointing part of doing in situ simulations is the frequency at which we get all of the equipment and all the people together to run the simulation, And then we're told, sorry, we're too busy. Sorry, we don't have the staffing. Sorry, the equipment isn't, whatever the excuses are. And to me, that's not a valid way of going about it. If we are pulling in the simulation resources to do the event, then we're going to go as far as we can. We'll create our report and then demonstrate that to the administration that says, this is what we found. This is why we couldn't go any further. And we won't go back until those fixes are made. And I think that's oftentimes the missing link. The simulation program can do their piece, but that report and the follow up to it and the changes that are made have to be conducted and done so that when we come back in a couple of months, we're not doing the same drill and finding the same things. It's okay if we find new things. It's not okay if we find the same things over and over again. And so with that, I appreciate everyone's coming online today and taking the time, and I'll stop sharing my screen and answer any questions.
Well, thank you very much, Professor Katzin, for this inspiring, very, very inspiring presentation. I think it's always valuable to see how things are made elsewhere. Like it gives us new ideas, and I believe that's the case for many, many of us. I personally have a question. What are the barriers that you have encountered in implementing in situ simulation in your clinical setting?
Yeah. The first barrier is just a hesitation to do it, right? Why do you want to do it? I think the second barrier is the understanding why it's important, right? So a lot of times people say, come do this and train everybody on this new thing. And that's not why I do in situ simulations. If I'm doing an in situ simulation, I want to check the process. If you want me to train people, schedule a time, send them to the simulation facility, send them for the educational training. The in situ simulations are short. And so the barrier, I think, is for our administrators, our non-simulation colleagues to understand the reason we do it, and then to partner with those process improvement individuals, unless you have process improvement as part of your simulation program. I find things wrong, but I need someone to go make those changes. And I think that's one of the biggest challenges is making sure that what we found is communicated and then acted upon.
Absolutely. And what I also liked, you showed us that simulation in situ is not only at the hospital, it can be anywhere, and that's very valuable.
I think it's valuable because healthcare isn't just episodic. It doesn't just happen in the hospital. It can happen from the time, you go and see the general practitioner, the primary care person, all the way through to calling the ambulance, to the rehab center, to wherever. And I think when we're talking about expensive equipment, personnel, we want to be able to demonstrate that it makes a difference, not just here, but across the board. And so I think doing these drills in environments and different locations and recording them and publicizing them and sharing the stories is really, really important.
You are absolutely right. We have a question from Denis Oriot coming from France. He says, thank you very much. What could be the prerequisites for going from announced to unannounced in situ simulation?
So I think it's the purpose and the rationale and the reason for doing it. We do a lot of announced drills, so we have to plan it with the department or the unit or whatnot. And that works because we're testing not the response, but the location of equipment or the functionality of certain things. We do unannounced simulations, and that's to test the response system. So we will bring our mannequin up and just pull the button on or push the button or pull to see how the people respond to it. But that takes a lot of buy-in from all across the institution to be able to do that. And you have to make sure it goes well. because you don't want a lot of people showing up and then being pulled away from clinical duties and other things. Um, unless you have the support to do that. So we've done that in the past, and we actually worked really hard on making sure that the response team knew where they were going, knew where their equipment was and what equipment to bring. But what we found was that everybody came. When we said there was a cardiac arrest, we had other nurses, other doctors, everybody walking by taking a look. And what we decided to do was to have security have a new role. So typically, security was keeping people away. Only certain responders could come in. But when we did our drills, we told security, keep everybody here. If you're coming to our drill, you're now part of it. And so you're going to stay. And people would complain very much that they had other responsibilities. They had to go see a patient. And so we said to them, but if you came to look, then your responsibilities weren't so great. You can stay for 15 minutes. And they got quite upset with that. But what we found was that instead of 50 people coming to a room for a code, for a cardiac arrest, all of a sudden, we only had the team that was supposed to respond because people didn't want to get trapped there anymore. And so we actually used the unannounced simulation as a way to decrease the number of unintended responders to the event, the actual clinical events that were occurring. So I think, the prerequisites are making sure you have good reason for doing it, making sure you have the buy-in from the appropriate people, and making sure you follow up and know and demonstrate why you're doing that event.
Thank you. Professor Mohawi, I think he wants to say something, please. I see a hand raising. Okay. Good, so let's continue with questions. We have quite a lot of questions. Norm Kawi saying, very impressive. How do you evaluate the impact of in situ simulation vs classical simulation in clinical behavior?
Yeah, it's a really, really good question. How do you measure this, right? And so I come from a safety science perspective, and I look at this from the challenge is that these events are so infrequent that we don't get a lot of data about it. And so I collect stories. I collect the qualitative feedback about how valuable this was. I also then take the report that we generate and demonstrate the risks that are there, and then the improvements that were made. So I can't say with any certainty that a patient was going to get the wrong medication or not get epinephrine, right? And they were going to get ephedrine or xylocaine or whatever it was. But I can say medication errors are a real challenge. Here is this opportunity for a medication error to be made. This is how they're made, right? It's not the person who makes it. It's not that they're not smart. It's not that they don't know how to do things. It's that they both had purple tops on them and they grabbed the wrong one. So we were able to put another barrier in place to help prevent that from happening. I can't say with any certainty that they were going to make the mistake, but we're reducing the likelihood of it. So I also collect the stories, the emails that I get that say, thank you for doing this. You did this drill, and a week later, we had this patient come through with this condition. And we treated them appropriately and timely, and we did the right thing because of the drill that you did with us. That may happen 6 months later, 9 months later, a week later, whatever the time frame is. Collecting that story and keeping a package of them. So when people say to me, why do you do this? I say, because this patient, who's a mom, who's a marathon runner, who has 3 children, went home because of this work. It doesn't change the lives of 1 million people. But you know what? She may go on and change the lives of 1 million people. So that work, those stories, I think, are really, really impactful.
Absolutely. Professor Mohawi, I
Yeah,
think
of
it's
course. Thank you, Mimet. Thank you, Jared, for your lecture. It was really very relevant and very insightful. I will have a small question for you. I used to run in Situ simulation for my teams in emergency department every week. I have a little concern about one thing because some providers may feel observed or judged. So how can we create a culture of psychological safety during those simulations?
So I think that it actually starts well before the in situ simulation. I don't think it's about creating a culture of psychological safety during the scenario. Because if you're doing it as an unannounced scenario, it is what it is. What you have to create is a culture in which simulation is part of what you do. Not just part of what you do, but part of what your organization does.
Yeah.
If your learners come down and know that what happens in their simulation facility, it's a safe space, that they respect you, that they're not fearful of you, that they can come and talk to you, that they can come and ask for help, that you will help them, that you will give them opportunities to practice. That when they see you up on the unit, you're friendly and you talk to them and you converse with them. When you show up to do your drill, it's just like another training. And they know that it's a safe place. And you create that safety during your debriefing. So what we want is people to come participate and stay for the debriefing. That's where we create the psychological safety of thank you for your participation. Let's talk about what you experienced. Let's talk about how we did. Let's talk about how we can improve upon this. And by the way, this is really great. We're only going to spend about 5 minutes doing this, and then we're going to get you back to your patients because treating the patients is the most important thing
Yeah.
that you have to do today. And so, thank you. Let's move forward. But it's not about establishing that culture in that moment. I think it's a lot of the behind the scenes work to establish that culture of trust.
Okay, thank you very much.
I know there was a question about debriefing.
exactly that's
And I dropped one reference into the chat already, and
Yeah.
there's another reference I'm going to drop in there as well. So the first one is a modified Pearls framework for debriefing systems-focused simulations. So if you're familiar with the Pearls model, this is a slight variation of that, focus on systems. And then the American Academy of Pediatrics actually has a clinical event debriefing program that is led by a very good colleague of mine. Excuse me. Her name is Lauren Zins, and Jabin Fayez is part of that project as well. And there's a host of other simulation folks. Lou Halamic is a name that you may know, who is heavily involved with simulation, and Nicole Keating from the American Academy of Pediatrics. But Lauren Zins is actually a faculty member with me at Mount Sinai. I helped develop the program. She is now rolling out her clinical event debriefing framework. That debriefing is actually for real clinical events, but we use simulation to teach people how to do those debriefings. And therefore, I think the framework is actually applicable to simulation debriefings in the clinical environment as well.
well, it helps us actually to train the trainees and the trainers, like both objectives. I think we answered the two questions about debriefing. And we have a question from Siham Baghdadi. She says, firstly, I want to thank you so much in Morocco Sim for the opportunity. And I want to ask you about patient safety outcome improved the most after you introduced in situ IPA simulation.
Yeah. Which patient safety outcome? You know, there's so many that it's hard to pick just one. Um, I would say probably response time when we're doing it, because our teams knew the environment better, they knew where they were going, they knew what equipment to bring. Um, but I don't have any firm data on that. But I would just say like the overall response time and the response process was improved. The time to getting the right care to the patient, whether that was defibrillation or CPR or medications or CAT scan. But the question that I then ask is like, okay, why did that improve the most? Probably because it's the easiest thing to measure, right? Like I could stand there with a watch and say, oh, we did it the first time. Look, it took us 12 minutes. Oh, the third time it took us 4 minutes, right? There was an improvement. We measured it. But there's probably some other safety sciences and safety mechanisms that we were able to put in place, like pulling off the medication so that they didn't look alike and sound alike. That probably was pretty impactful. Um, yeah, no, there's a multitude of things. The coordination, the teamwork, it's hard to measure that, but I think teamwork also vastly improved, the collaboration. So it's a good question. I don't have a really good answer for it, unfortunately.
I will continue with a question from Huda Ubja. She says, "Hi, thank you for this brilliant presentation. We started to do some interprofessional in situ simulation in the OR and the emergency department. Do you think that it's more appropriate to schedule one, or you don't announce it before?"
Yeah. Um, I'm a big fan of not announcing things, but in environments like the operating theater, scheduling and making sure that you have things appropriate is really important. I think it goes back to what your purpose is. If you wanted to make sure the operating theater team was able to get blood from the blood bank to the theater in a timely manner, then you can announce it, right? Bring everyone together, explain to them what you're going to do, explain to them how, the scenario and schedule it. Maybe you don't tell the blood bank, but you tell everybody else. But if you want to talk about a patient needing emergent surgery, and you want to mobilize the team and see how long it gets them to get to the environment and get scrubbed in and make the first incision, then I wouldn't tell them. So I think it's a little bit of both. I think it depends upon what your objectives are. As with everything in education and simulation, what is it that you want to do? And then which is the best way to meet that objective?
Absolutely. We will continue with Mohammed Darwish. Thank you for this thoughtful, provoking webinar. How do you ensure ISS transcends checklist-based improvement and truly transforms collective identity and leadership in fragmented healthcare systems? Interesting.
When you figure that out, you let me know and we'll do a presentation together. No, it's hard, right? It's really hard to make sure that it's not just that, like I said, checklist based times, and really transforms that collective identity. I think the way that we do that is through the repeated process, the number of times we do it. It's not just about doing it once to say we did it. It's about doing it time after time after time after time and demonstrating what those needs are and making those improvements. So the next time you come, you can say, look, this team functioned better together. Look, this team found this piece of equipment that they wouldn't have otherwise found because somebody spoke up, right? So you create that scenario that requires that really strange piece of equipment, right? That people may not know how to use. Or maybe it's the surgical airway, right? And everybody's afraid to do a surgical airway. But technically, and from a skill perspective, it's not that hard. The decision to do the surgical airway is the hardest part of that whole procedure. So maybe you start the first time and you do a simple airway case and you talk about intubation, you talk about the right equipment, you talk about the need for people to speak up because they didn't notice the O2 sat was dropping and they delayed. The next time you do it, the intubation goes a little bit smoother. They do it a little bit faster, but maybe it fails. And then you talk about the need for that surgical airway. And the third time you do it, they end up doing the surgical airway really quickly, right? So you start to see those improvements. And that's not a checklist, but it's just watching the team function better as a team. And you design that clinical scenario to be progressively more difficult, progressively requiring more and more communication, collaboration, speaking up, whatever it is, so that you can see that improvement as a group over the time.
Thank you very much. I think our last question from Marim Fortasi. She says, very interesting, thank you. Do you think in situ simulation could be used as a research tool to assess the transfer of knowledge and skills to real-life practice, Kirkpatrick level 4, which is usually difficult to measure in medical education research? Oh,
Yeah, so this is talking about whether or not you're using simulation for an educational tool or simulation as a testing tool. And I absolutely think it could, right? So you do a systems test and you see XYZ happen. Then you do some sort of educational intervention, right? It could be online learning, it could be virtual reality, it could be augmented reality. The challenge is to say that any of that education improved their performance. So you rerun the simulation, you see improved performance. Hard thing to say is this. Was a new computer system installed, right? Did they just have more time and training, right? Was there a new manager? Was it different staff members? So yes, I think it can be, but I think there's so many confounding variables that it oftentimes is really difficult to say, yes, this simulation training we did in this simulated environment translates to here. Of course, right? Of course, if you do an in situ simulation with a group, identify gaps in knowledge, bring them to the sim center, do some education, right there on the spot, do some education, and then go back the next day with the same clinical team and rerun your in situ simulation, and they do better, then clearly, right, either your debriefing or your clinical skills training or your simulations had an impact. But to say that it's going to impact the patients tomorrow or the next day, still a bit of a stretch. But I think it's working in that direction of using simulation as an assessment tool versus simulation as an educational tool.
I can see Professor Fortasi, maybe she wants to say something. She wants to answer? Okay. Okay, thank you very much. I don't think we still have time to answer more questions, but I'm very happy for our very engaged public today. I'm just gonna.
So there is one other question which I just saw, which is talking about AI and embedding that into in situ simulations, and I think that's a really interesting question, because I think we have to figure out how to adapt to AI and how AI is going to impact everything we do. So I think a couple of ways that AI can be embedded into in situ simulation. I think as we start to see more and more AI analyzing videos, right? If you're able to videotape your in situ simulations and compare those potentially to your real clinical events and have AI assess for similarities, I think that's really interesting. I think you can talk about, a lot of data mining from different devices that can track where people are looking, who can track your communication skills, communication styles. So I think there's a bunch of stuff there that we haven't even thought about. But I also think that AI can be embedded into our decision support tools and figuring out how to utilize it. So whether or not it's a head-worn device or a handheld device that has AI built into the back end, getting clinicians to learn how to use those devices, when it's appropriate to use those devices, and how best to use those devices as part of their workflows is absolutely the appropriate component for in situ simulation, right? Whether it's your EHR that has an AI engine built into the background and recognizes the vital signs, which flags certain things to happen for the patient. AI, we have to figure out how that gets embedded into our workflows, both from a simulation and clinical perspective. Sorry, Miriam.
It's okay. I think we will hear more about AI in simulation on our next event. I will share my screen with you. We will be hosting on the 27th of September, the International E-Conference on Training and Simulation for Patient Safety. And we are also glad to have Professor Jared Katzin with us. who's gonna hopefully talk about AI in simulation. You confirm it?
We will figure out dates and times. Yes.
Yes, big yes.
Okay.
Hopefully.
Amazing. You can also visit our website to have the full program. It's still not available, but it will be available next week. Well, thank you very much. Thank you, Professor Jared Katzin, for your insightful presentation. Do you want to add something?
I was just going to say, for those of you who did not watch one of the matches on, whichever it was, the Club World Cup or Copa or the Gold Cup or whatever it is, I appreciate you. But I was glad to spend some time with all of you today. And my email address is available. Miriam Mohammed have it. So please feel free to reach out. Happy to communicate.
Thank you very much. And thanks to the audience. Very engaging audience we had today. We finished with more people than we started. That's very good.
That means people stayed. That's a good thing.
Yes, that's it. On the behalf of Morocco Sim, I thank you all, and I'm happy to be welcoming you on the next webinar. Till then, take care and keep pushing boundaries of simulation in healthcare.
Bye-bye.
Thank you.